All right, welcome to our final session for this afternoon. The panelists from two different LHMAs are going to provide an overview of jail-based competency restoration programs. They're going to highlight how strong collaboration between mental health providers and courts is helping to reduce state hospital wait lists, improve restoration timelines, and ensure timely access to care. Please welcome Jonathan Lemuel, the Director of Forensic Services at Bluebonnet Trails Community Services, and Dr. Krystin Holmes, the JBCR and Competency Restoration Assessment Unit Program Manager at the Harris Center. Welcome.
I don't know how this works.
There we go.
It ain't on the screen. Oh, okay.
Yes, it is.
All right, good afternoon. I'm Jonathan Lemuel with Bluebonnet Trails. We want to talk to you guys about JBCR, basically. Starting one, you know, the collaboration and all the things that it takes to actually be able to have a JBCR. So we want to talk about the partnership. The partnership there, you can see from, I'm going to talk about Williamson County, what we did there to actually start our JBCR in a small county perspective, and Dr. Holmes here will talk about Harris County. And we'll just kind of go back and forth there a little bit there. Hopefully we'll have time at the end there for questions. We're in between y'all and going home. So we're going to talk about the partnership. The partnership there is all the collaborative agencies that have to be there to actually be able to support the program and support the client. So for us there in Williamson County, we have the Sheriff's Department, we have the local mental health authority, which is Bluebonnet Trails, we have HHSC, we have the District Attorney's Office, and the County Attorney's Office, and then we have the elected officials, the judges. I don't know what it is. Okay.
And my name is Dr. Krystin Holmes, and I'm from Harris County. And so just kind of we know the audience a little bit, how many of you guys already have a JBCR in the works? Okay, a lot of folks. How many of you guys want to start a JBCR? You're like, I really want to learn how to do this. Okay. And then how many of your folks are attorneys? I see my attorneys in the back. Okay, attorneys. Judges. Got any judges in the room? A couple of them? Okay, perfect. So again, this is about, we have a more rural county approach, and then Harris County, obviously, we're a huge county. Okay, so there are some things that we've already encountered just by because of our population, we've had to encounter them. And so this is coming from our perspective and how implementing a program like this can impact your state hospital wait list. At Harris County, we have over 350 folks on our state hospital wait list. It's a huge wait list. And so in collaboration with our counties and our county officials, this is how we've managed to kind of try and tackle this really big problem for us. So obviously, to serve the client, HHSC is one of our major partners, but Harris County itself is our major partner. We have great support from our district attorney's office, our public defender's office, both our misdemeanor and felony courts, and then our biggest partner is our sheriff's office. And so all of these systems have to work together to serve a single client, and we do it over and over and over again. So those of you guys that have JBCRs, you know sometimes the challenges you face just getting in the door, right? Getting a seat at the table. And so this is where we proponent host the party. If you host the party, you're always going to have a seat at the table, rather than someone else dictating, oh, this is how we think you should do this program, not having done the work, right? I know working in the LMHA, I've had that happen before. I go, I don't think we can do that. And it's, you know, so working through these systems, we're going to talk about ways to implement a program that's going to benefit your community. And it's not a one-size-fits-all, right? But we hope to give you a model and an infrastructure to where you can then apply this to your county and serve your population. So looking at kind of the main pillars, this is what I call the 6 core concepts for developing a JBCR, starting with the community and stakeholder support. You have to know who you need to support your program. If you don't have buy-in from all of these various people in your county, it's not going to work, okay? Namely your sheriff's office, because if you're doing a jail-based competency program, that means you're doing something in their jail, and you need their buy-in to do it. But you need the support of your county, the support of the LMHA, and everybody has to be on the same page to even push forward. The next step is going into that financial support. It costs money to run these programs. Sometimes we talk about heart problems, then we talk about headaches. Okay, people will pay to get rid of headaches, and then you have to know your audience, because sometimes you're talking about matters of the heart. These are pulling on people's heartstrings. Other problems will pull on people's purse strings. You have to know what to ask for to get the funding you need. Otherwise, you're going to come up short at the end. Next is your infrastructure. You're going to do it at the jail, so you need to talk to your jail and talk to your sheriff about how do we do this program logistically? Do I already have staff working at the jail? Some of the programs that we've worked with to help develop, they're like, I don't have a relationship with my sheriff's office, or we're not in the jail. How do we even do this? So having civilians go inside the jail is a very different experience. Okay, it takes a certain type of clinician. It takes it takes a lot of buy-in from the sheriff to bring people in for the purposes of serving the clients that are incarcerated. The legal processes. This is something, please get with your district attorney's office, your judges, your defense attorneys to iron out everything from admission to disposition of a case. How do I work someone all the way through on paper? Because the last thing you want to encounter is getting people started in treatment and then something happens, you don't know how to get them finished. So I'm not an attorney. I just, play one from Law and Order, my Law and Order degree, that's all I've got. And in counseling school, they didn't teach me how to be an attorney. And so I have to get with the folks that know to say, how do we legally do this the right way? The fun part is your program development and design. That's why it's almost last, because you have to iron out all the not fun pieces first, but then you get to decide, how are we going to do this? How many clinicians, what type of clinicians do I have to have? What type of services are we going to provide? Are we beholden to a contract that tells us what to do, or are we county funded and we're coming up with things on our own, right? And then you have to track data and outcome metrics. You have to get data to support and go back to your communities and stakeholders and go, hey, this worked as a pilot, we want to do it long term. Maybe we need more financial support. That's what we learned out of our pilot phase. But you have to know how to track and what to track and who to deliver it to.
So as you're starting your JBCR, most of the time you're going to look at the medication. So court order medications is a major factor in a JBCR program. If you can get that person where they're already on medication, as they come to you, if you're going to try to start the medication once they're in your program, then you kind of lose time there. So you want to actually be able to work with your jail and work with those systems where you can actually get those medications compelled before they actually make it into your JBCR program, so you're not losing time there stabilizing them on the medications. So we want to look at, what is individuals' mental illness, what does it look like? Why are they refusing their medications? I mean, have anybody ever talked to them about that? What's going on? What are those factors that are stopping them from wanting to actually comply with medications? Then, we want to look at, what is the best medication for that client, and is this done in the best interest of the client to actually compel them with the medications?
Who already has compelled medications on board? A couple? Are there any places that refuse for compelled medications or court-ordered? A couple, yeah. So this is one of those areas that, it requires psychiatrists to testify. And to do some things. And so that's where you can kind of run into a philosophical clash, right? And so that sometimes happens. What we have done is we've had our doctors talk to other providers to talk to them about what is the barrier for them, and then, is there a barrier in the county? But there is a purpose. And when we talk about all these things, it's in order to be efficient with your resources, with your time, because allowing someone to languish long-term, justice delayed is justice denied. So we're trying to get people to the place of best fit as quickly as we can, so that way their case can continue and they can get to an outcome, right? We're not tied to the outcome. We just want to help someone get there and to be able to have a say in what happens with their defense.
Some of those times are relationships. If you have those good relationships with the county jail, then you're able to actually help them educate and understand the reason for compelled medication.
So when we talk about what is the purpose, so the purpose of all of this is to help people who lack the capacity to make a rational decision regarding their medication. So, you're talking about folks who, when we look at, there's a lot of different reasons to compel medication. But when we look at what is the benefit, right, there's always a cost-benefit analysis that we do. Someone might adamantly refuse medication on many different grounds. There's reasons for doctors to go to court on patients. But when we look at if you are a danger specifically to self and others, that safety factor is probably going to outweigh objections. Okay, and there's times and places in which we can compel medications and times that we can't. But the purpose is to help the program and the patient to complete as successfully and as quickly as possible. And sometimes too, we have folks that will start in JBCR and maybe we get them on the compelled medication process and then their number gets called to state hospital. That happens a lot. And for us, we just look at it as, okay, maybe we've helped the state hospital get a leg up, right? We've already started them, we're getting them down the competency track, so maybe that person doesn't have to spend as long at state hospital, but we're never gonna deny them that treatment, especially whenever it's their turn to go.
It shortens the time in jail. It's really, really good. Sometimes they don't even have to go through competency restoration. Once they start on the medication, then they stabilize and they're able to move on. So there's tons of benefits there. It improves their quality of life, because the longer they're in the jail, it's the mental health professionals in the room understand, they're in psychosis, they're doing more damage to their brain. So we want to get them on medication, get them stabilized. Cause less problems in the jail. You have less uses of force. You have less problems there. Less aggression. It's easier for the jailers. The jail is not losing staff members. Also, you kind of look at it in another way. Compelled medication is really expensive, but if you go back and you look at somebody waiting on the wait list for over 500 days, you're spending the money in another way instead of getting them compelled and getting them moved through the court system a little faster. I mean, we have some statistics that are from the small county and the big county that we'll give you guys here in a little bit. But then it decreases the state hospital time. So if they're already coming over to the state hospital on medication already, so then they're going to transition back to you a lot faster. So we're able to open up beds also for the civil side, and we're not always taking up the beds on the forensic side.
I mean, if you think about, and this is where you've got to get with your jail to find out, what does it cost to have a mental health inmate, daily cost of living, right? So if it's just, because I'm bad at math, if it's $100 per inmate per day, right? $36,500 a year are going to nothing other than housing, right? So this program might cost you to do. You might have to, there'll be some county funding, some state funding. There'll be some things with the compelled medications. The medications might cost some money, but at the end of the day, they're getting some treatment and they can be out of your jail faster. They can be moving on to their next step versus just sitting there eating, sleeping, breathing, not receiving any treatment or help whatsoever.
So when you move into the forced meds process, it's a two-step process. You always start out in probate court. So there's a process in 574 subchapter G where you're actually going to start there when you're looking at compelling that person with medications. And if you miss that case, you don't actually win it in the probate court, then you move over to the criminal side. It goes back to the criminal court where the case originated at and it's heard in front of that judge. That's usually an easier place to actually get compelled medications in the criminal court than it is in the probate court. There's a little less that you have to prove up there. You still have all the requirements, the capacity standards, to actually be able to compel that person. You have to go through all those steps, You have to make sure that, the patient, you have to take the patient's account in there. The patient also gets an attorney, so he has that representation there, as we're kind of, working on that. Do they lack capacity to make decisions? So is this person that's just somebody there that really doesn't understand what's going on, doesn't understand the benefits of the medication? So we want to actually look at that. We also want to follow what the Health and Safety Code says in 574. It's our guide. And we want to look at the dangerousness standard. Is this person somebody who's really dangerous there in the jail? Or, what they're doing, is it dangerous to somebody else? So how do we actually be able to, we get them on compelled medication, nobody's getting hurt, they're not hurting themselves, they're not causing a bunch of issues there in the jail. So that's a definite benefit to actually move over to actually compelling them with the medications. There's other standards in there you have to actually follow as you move through that. I don't feel like I have to go that far into it. Usually your doctor is going to be making those recommendations.
So when we look at dangerousness, you're looking at the assessment of their present mental health condition. they're inflicted, attempted to inflict, or make a serious threat of inflicting substantial harm to themselves or others while in the facility. I'm sure many of you can think of patients are already popping into your head that this person, they're prone to hurting themselves or hurting others. If they can't be in a group type of tank, they have to be in administrative separation. We have those too. So when we look at what is the dangerousness standard, we're always going to go back to the health and safety code. You're looking at 6 months preceding the date placed in the facility, and again, all the things that lead up to, is this person actually dangerous and are they going to cause harm to others? You can get compelled medications without, if it is for the purpose of competency restoration only. And again, our doctors, we talk about it a lot. There's been several cases where our doctors have said, hey, for various reasons, I won't be pursuing court-ordered meds. And from a clinical perspective, I respect their decision, whatever that is. We talk about it, and I would understand their rationale for it if it would help them to restore to competency and why they're not pursuing it. But sometimes it's a medical reason. We had one individual that, due to the damage to his liver, he just couldn't take any more, medication was not going to work for him. So we were going to restore him only with the programming and the behavioral interventions, because doing so would physically harm him, and our doctor was not going to do that. And so he didn't end up restoring. It wasn't a shocker, but he was one of our best and well-behaved citizens of our pod and did a great job while he was there. So I think he personally benefited from the program. And then because our court was able to get a disposition on him after the competency evaluation, then we could do things with his case. But everything stops until they can be evaluated and go through a competency program, and that's where people just get stuck languishing forever. So when you talk about the best interest of the patient, again, they're going to talk about, when the doctor sits with them, they should be asking them these things. What is your, as Jonathan said, what is your preference to medication or reason you don't want to take it? Is there a religious reason why you don't want to take this medication? You have to explain all the risks and benefits of taking a medication, the consequences to the patient if the med isn't administered. What is the prognosis? And are there any alternatives? What's the least intrusive way? You have to talk about all these things, not just with the patient, but with the probate court. When you go and testify, they're going to ask the doctor, are you going to provide least restrictive means? Are you going to offer the patient medication orally prior to administering an injection or things of that nature? So the court really does a good job making sure that we provide the patient every available opportunity. And typically it only takes, it may be 2 or 3 forced medications before they either clear up, their psychosis goes away, and they go, okay, it's fine, I'll take the medication as prescribed. We had one guy who just didn't like to swallow pills, so he was getting an injection every day, and my doctor's like, what's going on? This is not normal. And come to find out, we just switched him to liquid, and he was fine. He just didn't like swallowing pills. So, but it takes that time and attention to detail and having staff that's going to go encounter your client and go, hey, what's going on? There's something abnormal here. How do we help? How do we help to fix this?
Most of the time, most jails are afraid to do compelled medication because they think about the use of force that they have to actually administer to get the client to take it. Usually it's only one-time show of force, and most of the time the clients are actually being compliant and just willing to take the medication. So you're able to, we just bring people down now, and they're on forced medication, they come down, they take their injection, and they move on. There's no show of force anymore. All right, so we transition over into, what does it look like if somebody's actually moving through the system? We want to order them into JBCR and order them out of JBCR. So in Williamson County, when we started our program is fairly young. We're going into our 3rd year right now. So the courts, the court coordinator figured out, we were going to play Candyland, basically, with the Candyland charts. It kind of just navigates you through the system. So as we're bringing someone in, we have the steps. We order them in. Step 1, we're going to raise concern. So, are they finding of incompetency? So there's the order for the doctor to come in and actually do the evaluation. I'm going to go really fast through these because I mean most people know how you get through that, but this is our process. So that if we do have a new attorney that shows up there, this is the process there in Williamson County that you can actually get somebody all the way through and you know what's going to happen. Then there's the order is signed. And we're gonna, I can't see what that one says. Then we have the order of commitment. Then we have the agreement. Then we have the request that comes over to us as a local mental health authority to do the evaluation.
I think one thing that's very important when you're developing a program is to be able to have some autonomy in developing your program, right? Who do you order in? Who do you order out? Who do you assess? So we do orders for assessment, so we're able to screen our clients rather than just having someone order them straight into our program, because that person might not be appropriate for a JBCR. Many folks are appropriate for JBCR, but if there's someone who has never restored at state hospital and maybe they've lived in our most acute unit that we have there at the jail forever, that person's probably not going to be best served in JBCR. And for us, it's about when we do assessment, we want to get the person to the place of best fit. Sometimes that's OCR, and if we can get them out in OCR, we'd love to do that. If they're appropriate for JBCR, we'll take them in JBCR and start them down that process. And maybe they finish with us, maybe they don't. But for those folks that really need state hospital, we want to get them to that highest level of care. So if we can serve all these others at JBCR, we want to do that so that way those folks that really need that high level of service can get there. And so that's really the purpose of all the assessment pieces, so that way you're able to control the flow in and out of your program. The last thing you want is to have 100 people order in and you only have the staff to serve 20 at a time.
You're making sure that you get the right people and the right paperwork is actually following them through that whole process. So we have our recommendation letter that we send back to the courts that we feel like this person is appropriate.
They stole that from me.
We copy and stole everything.
Yeah, we share everything. We are willing to share. We do a lot of form letters. The court gets regular updates from us, and that's per our contract, but also just because we like to give them updates. If there's a change in condition or presentation, we let our court know that, hey, this person is really not working out very well in JBCR. Court, do you want to save their bed days for state hospital? And then we'll just programmatically remove them. So it's not it doesn't count against us, but it does stop their days from continuing to accrue and utilizing their 073 days.
So we move into program eligibility. What does it take to actually come into our program? For us, we want to make sure that they are compliant with their medication. So if they're already on court order medication, then they're already compliant. We look at what is their living situation like in the jail. My situation there in Williamson County is a little different than the situation at Harris County, where we're actually housed in a pod. Our office is there. Everything is located right there in a 48-man tank. So we do everything inside of there. So we want to make sure that as we're bringing people in, we're not disrupting the milieu as we bring somebody else new in. So we try to bring in cohorts of 10 at a time, so that we have that cohort, as we work that cohort through the system, we don't have that many interruptions, and we're able to kind of get them restored pretty quickly. We want to make sure that their willingness to participate. Between the hours of 8 and 5, it's a structured hour. You're not able to come in and take a nap and do all these other things. So we want to make sure you understand these are the requirements to actually come over. I mean, there's no showers at 12 o'clock. There's no going to go take a nap. It's basically almost like you're going to work. You're at work between the hours of 8 and 5. Lunch is bought in there. We give them a lunch break. We allow them to have lunch. If they need a bathroom break, we do a bathroom break. We also do something pretty unique there, where we have on our pod, it's a male and female. So we bring the females over. So when we're doing group, the females are in the tank there with the males. There's a female guard in there. So we're all working together. So it's easier, we're asking the jail to do less by being able to do a male-female group at one time. Because when we first started, we had a tank that we just had females in and we had males in. So we had to ask for more security staff to be able to move across the jail. So we found a little standard in there that said in treatment you can actually cohabitate. So we showed that to the jail, and they agreed, and we were able to cohabitate and have those where we were able to actually move through that a lot faster.
Harris County is not letting us do that, I'll tell you that right now. No, we'd probably have more participation and buy-in if we did let the women come too. So we still have the model where they are separate. We are in the treatment, so we have our designated dorm units that are program tanks, and our treatment team comes to the program tanks. We do have the similar as far as structured setting goes. We have hours and times and things that we're doing. And the patients are expected to participate, and they like being in that pod. It is a little bit, it's nicer, it's cleaner. They have people coming every day. We do JBCR karaoke, which if you've never seen that, it's awesome. We do a lot of recreational activities, including outside time, like outside, sky outside, that other pods don't get to do. But no, they won't be letting the ladies come anytime soon. I can confidently say that.
I mean, the difference in the size of the jail, you know, we have to do things that make it fit the size of the jail so that we're not putting too much stress on the sheriff's department. Because, I mean, we are a guest in their house, so we want to be able to make it easy as possible for them and also easy as possible for us. I don't have that large of a staff. You know, here's our jail-based competency restoration. This is our team. As you see, it's a very, very small team, but, I mean, they do great work. Basically, the 3 young ladies on there actually work with the clients every day. Our nurse practitioner, Courtney, comes in twice, every 2 weeks she's there, but we do staffings every Monday morning, virtual, and if there's an issue that's going on, we're able to quickly get them back in front of her, make an adjustment, get that downstairs to the medical department, and they're able to get a med change in pretty quickly.
So we actually have 2 identical treatment teams. We started as a 20-bed pilot program, and then we expanded. We're now a 50-bed program. And so because we have up to 50 patients at any time, we do have 2 identical treatment teams. So you've got your administrative folks. We're kind of at the top there. And then you have every team has a doctor, a nurse, a peer educator, or peer support specialist. Our peers are fantastic. I will tell you they were a little bit difficult to get into the jail initially, but now that they're in, they're awesome. So if you want to learn more about that, please feel free to ask about getting peers in. Those are people with lived experience in mental health, incarceration, or substance abuse. Then we have our LPHAs who oversee 2 care coordinators. And again, like I said, there are 2 identical treatment teams. We also have a forensic psychologist. This was a really good move because we don't have to wait to get them reevaluated. When they're done with our program, we have a designated 0.5 FTE forensic psychologist, and she does all of our evaluations as soon as they're done. And then we also have a court liaison who is our administrative support, because there's a lot of paperwork that goes back and forth on these guys. So this is our team. It is very large, but we also serve a lot of patients. So it's just, again, difference in larger population and a little bit smaller population.
So there's our pod. We call it J-Pod. We have bean bags. We have, you know, a whole lot of different things in there. And in the beginning, you know, we didn't know what we were going to be able to have, but we asked. And as we worked with the jail and we talked about, you know, for us, it was the defense attorneys who said the jail is not a therapeutic setting. So we had to figure out how to soften up that pod where the defense attorneys actually would agree with us. So we have bean bags, we have a carpeted area. You can see where one of the pods there is our actual office where we actually meet with people individually, do counseling sessions. We do televideo appointments where in the beginning where they have to see the psychiatrist, because we contract with ETBHN for the psychiatrist, so they see the psychiatrist there on the unit. If our nurse practitioner needs to see someone in the middle of the day, because we feel like there's something that needs to happen and change, we can bring them in and they can be seen right there. The guard post is there, the guard is there. Basically, we run the unit, and if they need to come down, they come down. We do mock trials. Sometimes we don't have enough people, and the CO in there will actually participate in the mock trial, maybe as a bailiff or even sometimes as a judge. So we utilize everybody in the pod. So
yeah, our goal is, I want the DOs to be fighting over who gets to work our tank. What did they call it, the retirement tank now? So they only put the folks that are on, like, I don't know, modified assignment, or they said folks that are in retirement phase, because our tank just doesn't have issues, knock on wood, right? We don't do fights. We have a lot of conversations about appropriate behavior in our JBCR community. So we do have a traditional little classroom set up as well. The pictures that you see are from one of our mental health awareness month days. So the patients got to paint their own mural in the tank. I got special approval by the chief. I gave him the design and the colors and whatever else, and he said, please don't arm 48 people with pointy things. And I said, no, we'll do like 8 paintbrushes at a time. So we actually had origami We had line dancing and paint going all at the same time on both sides. That's actually 2 different pods. And so me and the sergeant were walking kind of back and forth, supervising, and everybody had a great time, and we accounted for all the tools, everything that we used came back. And it's so funny because all the naysayers were like, oh, that'll be messed up in 2 weeks. They're gonna trash it. The first time someone gets mad, let me tell you how protective they are over their mural. They're like, you will clean around the mural. You will not mess up the mural. They ask me for paint to touch it up all the time, you know, like when it flakes off and stuff. And I'm like, look guys, we'll just repaint it, it's just paint. You know, we can do it again. So it really gave them some buy-in into their tank, and they take care of it. Next slide.
Yeah, those are, I can say our tank as well is like the cleanest tank there in the jail. Smells fresh. I mean, if any of you ever worked in a jail and you come in, it actually smells fresh all the time and it's clean, and the guys take pride in cleaning it up. You know, like Dr. Holmes says here, they don't have bean bags, but you know, we have bean bags, and the guys, they shower because, you know, nobody wants to, you know, be on a smelly bean bag, so they make sure that they're taking care of themselves. Their hygiene is very good there.
We also do what are called empowerment days. So we actually have, it's a minimum security level across the street. It's actually the Women's Empowerment Center. So we started with the women going over, and our chief of the jail said, I cannot house Maximum over there, but Maximum can go visit. Okay, so literally the jail coordinates with us to bus people across the street to go have their empowerment days. And we've expanded to the men now. The men can come over too. They utilize the exercise equipment. My psychiatrist is also a certified yoga instructor, so we do yoga in the garden. They're able to plant things and then check on the growth, you know, the next few weeks when they come back. There's basketball courts, like there's a whole bunch of things, and we use it as a behavioral incentive. You only get to go if you're adherent with your treatment, including your medications. If you're not getting in any, you know, no shouting matches, you're coming to all the groups and things that you're supposed to be doing. And so when we take certain folks and other folks who go, look, I would love to take you, and I hope that you can come next time, but that's entirely your choice. You know, so we emphasize a lot of personal choice that goes on in a place where they don't have a lot of personal choice and agency. And so they'll go, okay, miss, I'm going next time. Okay, well, do the things you're supposed to do, and next time we'll see about you coming across the street. And so then when the guys get back, they're like, that was so great. We played basketball, and the DOs played with us, and it was so fun. They're like, well, I want to go too. So then they start behaving better. And again, the whole goal is to keep everyone safe. The people in the program, the detention officers that have to do supervision, us that are in there. We don't have a detention officer that goes with us. We walk in and out of that pod anytime, day or night. And I feel very comfortable doing so because of the relationship we built. Your best defense is a good relationship, but you still have to keep your head on a swivel, right? Every day is a new day in mental health. But by and large, our patients also tell us, hey, no, miss, that one, he's not okay today. You know, like he's not taking his meds, so just I'd rather you stay over here. So we really build that good relationship with our folks in order to best serve them, to try, and they know we're trying to help them. And so there's so many benefits to this program. And if you're thinking about implementing one, I highly encourage you to do so.
It's just a human factor. When you bring the human factor in there, you know, people get better really quickly. So we have JBCR curriculum. We use the Competency restoration curriculum that was provided by the state. We also use the manual that we got from Dr. Holmes, the Florida manual. And then we actually combined a couple other things that we've been able to find that we felt like was really, really beneficial. Is we're working with the clients and kind of meeting them where they are. We do a lot of artwork. We ask the clients to actually draw. We do a mask session that we actually got from the state hospital when we were down in San Antonio, where the people were actually making masks. So we asked the clients to make a mask right when they come in, and describing themselves, and then we have another mask at the end, you know, how they feel after that. So just to see, you know, to see the change and the benefits that happen while they're actually in the program.
Yeah, we do a lot of vision boards and things like that to help them kind of, the first thing to be incarcerated is the body, and the last thing to be incarcerated is the mind. And so we really work on, if you are getting out of here, what are the things that you want to see in your life? How do you want to foresee change? Let's manifest that change before we ever hit the street, because it's going to be really tempting to go back to your old behaviors. We utilize the Comp Kit mainly because when we started this in 2020, the state hadn't developed their curriculum yet. It was in the works. And so we use Comp Kit and the state as like the backbones and the skeletal structure of our restoration education. And then we use a lot of supplemental curriculum. If someone is, you know, maybe they're not formally diagnosed with IDD, but they're really struggling to understand concepts, we use the Eleanor Slater method from Eleanor Slater State Hospital. So we utilize a lot of different modalities, but at the basis of it, we have CompKit in the state curriculum. And that's been really helpful to have.
So we have the benefits, for the state in Williamson County, we have reduced referrals into the state hospital. So in our 2 years there, actually working in our JBCR program, we sent 2 people out to the state hospital. We sent one when we first started, and we sent one just the other day because he actually came up on the list and he still had time, and we were having a little difficult time actually working with him with getting him stabilized on medication. We have an efficient use of the resources. We're able to do a lot of things there. We're not having to send deputies out 5-6 hours to go transport somebody to a hospital. We have timely treatment for the lowest and highest acuity of the client. We don't have to take a chance of putting somebody in a car and send them off somewhere. For the courts, we have monthly staffings where we're actually sending that information across. Our care coordinator is constantly meeting with the courts, and we're talking about those different cases and working with them so that everybody's on board. When this person's competent, they understand that, and we're ready to get that person into court really quickly. The participant is a reduction in, their treatment is there. They know all the players. They've already met us when they came into jail. They met my staff downstairs, and so they know who we are. They're not going to go transition to go learn a new treatment team. They already know the treatment team. They already know all those providers there, so we're not having a disruption in treatment by keeping them there. I mean, that's also, even in Harris County, there's not a disruption in treatment because you're able to know the client and learn the client and know exactly what it is. Also, we have a competency graduation, so every time, we have a cohort, we actually do a graduation. I come in, I sign off on their certificate that they've been found competent. The jailers, usually the chief will come over, sometimes the sheriff will come over, a couple of lieutenants will come up, we'll have a small celebration. Most of these guys hadn't had anything or hadn't been rewarded or told that they did a great job in a long time. So we have that little celebration, usually about 15 minutes, and then we move on to the next thing that we're doing.
So just in looking at a little bit of data, so for 2024 and 2025, our restoration rates, it was 90% in 2024, 85% at the end of fiscal year 2025. We had 150 admissions, an average length of stay of 76 days. It was a little bit shorter in 2024 at 58 days. One of the things that I think really contributed to our success rate, we do something called a client-attorney structured engagement or a case session. Honestly, we just repurposed Zoom. And what we do is we connect the attorney with their client and then the clinician who's built rapport with them. And the purpose is to get on the same page with their attorney, right? So before I put this client up for competency, because remember, I'm not an attorney, we're not attorneys, I want that defense attorney to take a look at this person and go, Krystin, I'm almost there, but there's this one piece that if they just understood this, I'd feel confident saying that they're competent to stand trial. So it gives us information. We can pivot in real time because I don't want the person to go up for evaluation and not be successful or go in front of their attorney and their attorney's like, I disagree. And so having our case sessions allows us to really understand what is it that our attorneys are looking for specifically. That was something we implemented, a few years ago, and it's been really helpful in getting us to the finish line with a lot of our folks. Conversely, the attorney can say, hey, I really don't think that they're improving at the rate I'd like for them to see. Can we save their bed days? And we're like, yeah, sure, that's no problem. So now, instead of them being a loss in our program, they now are saving those bed days to go to state hospital. This past year, 2025, we received 443 requests from the court for assessments for OCR and JBCR. We completed 350, it's actually 353 of those, and we referred 48 people to OCR. Out of 350 folks that were assessed, 48 were appropriate for OCR, and that's because by and large, they weren't adherent to medication, they were going to be a flight risk, or they simply could not go because of dangerousness, right? They needed to be in a very secured setting, which our OCR is residential, so it is not. 260 of those folks fell into JBCR. We could treat them in JBCR. We'll get them started. They may not finish out of us, but we feel comfortable trying. And then 45 folks we recommended to remain on the state hospital wait list because that is where they'd be best served. So if you look at kind of your distribution, you have most of these people are falling within that one standard deviation of where they can fit. So JBCR is a really good option for getting people treatment in a quick manner. As far as court order medications goes, 47% last year, and this year we're down to 25% on court-ordered meds. So, and I attribute that to the rapport.
So our data there is a little different than there. So we had 41 people in FY24. Our average length of stay was 37.9, 97% competent. Then we averaged 8 days after they've been restored, eight days to a ruling in court. So moving them through pretty fast. In FY25, we did 45. Average length of stay is 36.4, 97% restored within 60 days. Average time to court was 11 days. So we have a smaller structure than the larger county, where we're able to get those things kind of moving pretty quickly, and we are able to move the city of 10,000 compared to the city of 700 where I am. It's a little easier to move things and have a lot of moving parts, and those great working relationships to be able to ensure that the client is, once they're stable and they're competent, we're able to move them on through the court system.
But I think the outcome measures are not unique. I mean, you can replicate it. You can do this too and have similar findings on your numbers. Again, we have a lot of systems in play in Harris County, so I'd love to have the time to disposition of 8 days, but a lot of factors at work. But we have this wonderful relationship with our courts that allows us to have staffings to get to our defense attorneys and our prosecutors work together to get the best outcome for our clients and the justice system at large. So we're very appreciative of that.
So once they're restored, we send our letter over. We also do the same thing that Dr. Holmes does, where we make sure that the defense attorney is on board. So before we ever send anybody in for competency, we send them in and we ask the defense attorney to come over and meet with them. So once we have that, we get them evaluated, we get that letter sent over. Time consent, I'm gonna move through this one pretty fast. It looks like we have 3 minutes. So we did a little bit of where we actually looked at a timeline of how long it actually was taking someone to get to the state hospital. So their arrest date was 4/16 of 2023. They were deemed incompetent on 5/13. And then by 8/16, they were admitted into JBCR. So a little bit of time there. That was a part of getting them on medications, getting things started. They actually stabilized. On 10/10, they were determined restored. 10/27, the case was resolved by plea, and the guy was released from custody. Go back and look at the same case. They would have went to the state hospital on 5/25. They would have probably been there around 216 days. Then they would have transitioned back and actually came into court on 12/27. So our process in JBCR went a lot faster than actually sending somebody out to the state hospital and waiting for them to actually get to the state hospital. So actually having a JBCR and actually having all those things really move a lot faster there, because you're actually able to work with the client right there, work with your system, and have all the players there at the table as you're actually working through these cases. Clicker's not working no more.
So that is the end of our presentation. Do you have any questions? We have a couple minutes or comments. Yeah.
Points. I think the first one for Mr. Lemuel, if I misunderstood you, I apologize, but if I didn't, could you explain? You said that at sometimes where someone is forced meds, they regain their competency and then bypass the whole the restoration process. The next one is, are these case sessions, are they, for instance, Harris Center initiated? Are they attorney initiated? Or who initiates that conversation between attorney and client? And the last one is, are there statistics where, because I know it's a big issue, all this is just wait lists, right? There's a wait list. I know there's a wait list for JBCR once they've been determined appropriate for JBCR, and to get into that, to get a bed. But then oftentimes, or not often, but sometimes, once they're in JBCR, they can't complete the process and they get sent back to the hospital wait list. Are there any stats on those?
Okay. So the first question was about the
Forced medication.
medication.
So starting somebody on forced medication, sometimes when that person gets medication on board, their psychosis, their symptoms calm down, and you're able to work with them, and they're able to understand why they're there. Then at that point, they understand the pleas, they understand the whole process. I mean, they're not in the throes of psychosis anymore, so you're able to move forward. So they don't have to go through JBCR and actually relearn the court process and learn what's going on there. You're able to the LPHA actually comes over and does another screening before we actually bring them in. And then when she feels like they're competent, then we're asking for the lawyer to come over and actually visit with their client. And if we all in agreement, then we ask for a new competency evaluation.
So it'd be called a spontaneous restoration, and that can happen when, if the mental health factor is what's preventing them from accessing maybe information that they had already had and what they want to do with their case. We need to get them stabilized first, and then sometimes that can happen. So we do the same process where if we think that somebody has regained competency, just by the benefit of being on medication, we'll reach out to, we'll file what's called a capacity letter stating we think this person has regained competency. Can we please get a new evaluation? We send it to the court. If the court agrees, then that gets completed. As far as the case sessions go, we're in constant communication with our courts and our attorneys. So the program reaches out to the attorney and says, hey, your client, we're potentially thinking about putting them up for their competency evaluation. We invite you to a case session if you'd like, to get a glimpse of what your client looks like now and to provide us any feedback in real time. And so again, it's not for privileged communication. We very much say we don't want to know about any privileged stuff or strategy. We're just here to facilitate an engagement to where, because sometimes, especially with our attorneys that don't do mental health every day, they're like, oh, they're still a little psychotic. And we go, yeah, they will be, but they're able to be redirected, right? So Mr. So-and-so, remember we talked about this doesn't have anything to do with your court case, but if you want to talk about this is what your attorney is here to talk to you about. And so the attorney is able to see that the client can be redirected. And they go, you're right. Yeah, here's what I want to do. I want to take the 5 years. I want to get out of here. So, but the team does initiate that contact, and we're in communication with them regularly. Everybody, the courts, they're pretty regular.
Sometimes educating the defense attorney on mental health and what signs and symptoms actually look like can be very beneficial for the client and the attorney being able to work together.
I think the last one, I'm sorry, I wasn't clear on the last one.
On waitlists for JBCR, and eventually they'll pass the JBCR and have to just get back on the
Oh, so for us, we don't ever remove someone. So when someone's in line waiting for JBCR, they're never losing their place on the wait list. They will continue to move their way up the wait list. And so that was one of our selling points to our attorneys when we first started. We never prevent someone from going to state hospital. Now, if we have them evaluated and we have an opinion of competent, we might say, hey, we just evaluated them and their report will be back in a day or so. And then the attorneys can decide if they still want them to go or not. But we don't pause people. We don't want anybody to stop moving their way up the wait list, if that makes sense.
Yeah, we don't take anybody off the list either. The only time they come off the list is once they've been restored.
Well, thank you to our panelists. This is going to conclude today's session. A couple of quick announcements. I want to, first of all, just put a plug in again that there will be the networking reception out front of, I believe, this ballroom, the Legends Ballroom. It's been generously underwritten by the Hogg Foundation for Mental Health. So please participate in that, visit with your colleagues, and meet new ones. We've also got resources available. Booths are set up by nonprofits and agencies and hospitals. So that's going to begin now and go till 6 o'clock. We're going to convene tomorrow in the Legends Ballroom at 8:30. Breakfast begins at 8. If you're a law enforcement officer, please join us for breakfast and coffee in the Discovery Ballroom at 7:30 for a short presentation by the Texas Law Enforcement Peer Network and a peer-to-peer discussion about mental health. Couple of additional items. A reminder, there's a drawing for the ASK bags at the reception. During the networking hour, the commission has posted some committee signs. So if you want to identify specific committees or network with other committee members, please keep an eye peeled for those signs. We've got them set out for the Rural Committee, Substance Use Disorder Committee, the AOT Collaborative, and the Collaborative Council. So thank you very much for being here today. Please enjoy the reception, and we'll look forward to seeing you again tomorrow. Thank you, and thank you to our panelists.